Me up.
So just a second, I'm just going to. Hello, everyone, and welcome. This is our second webinar of their summer webinar series, and we're very excited to have you here today. So for those who don't know me, I am Lee. I'm the manager of Rondo Seminars. I've been working with Dr. Rondo and Rondo Seminars for 21 years. Today, we have Dr. Rondo speaking on early orthodontic treatment, and excited to share this with you. This is the second of many of our webinars that we have throughout the summer. They're including, the next one is clear aligners, selecting the perfect case with Dr. Derezi, functional appliances with Bill Van Evans, best case finishing tips with Dr. Mike Lowry, practice management with myself, and utilizing bite turbos in orthodontic treatment with Dr. Mike. So to all those that are registered tonight, you will be automatically registered in to the remaining sessions as well. So please, plenty of room, share it with your colleagues, of course. And just a little bit about the platform. So you're in a Zoom, just feel free to use that chat feature down there during the webinar for any questions you have. We're going to take the time to make the time to answer them at the end, as many questions. And you can also reach out to me if you have technical issues in there. I will be paying attention to that. If that is impossible, you can also email me at Lee@Rondo Seminars. I do keep my eye on that while we're doing this. Okay, so a little bit about Dr. Rondo. He's been teaching orthodontics, TMD, snoring, and sleep apnea for over 35 years worldwide. He had a very busy practice in London, Ontario, where he only treated patients with orthodontic, TMD, and sleep issues. Now retired from practice, he has more time for golf and teaching. He has trained over 25,000 dentists worldwide on how to incorporate these much needed services into their general practice. He's published over 35 articles and has published the Early Treatment for Children book. Dr. Rondo's passion for knowledge and his systematic approach to airway-focused orthodontics has made him one of the most sought-after lecturers in North America. We are very happy and excited to have him here to share tonight his wealth of knowledge on early orthodontic treatment. Take it away, Dr. Rondo.
All right, Lee, thank you very much. And come on and get me set up, Lee. So welcome, everybody. And we're certainly happy to be here. I was playing golf today, so I enjoyed it very much. And so I've got some great case to show you. And I want to introduce you to Bill Van Evans, who's a lab guy that I've been working with, Orthodent Lab, for 30 years. And he's made me, I guess, 35 years. He's made me thousands of appliances and made many, many patients happy. So today we're talking about early orthodontic treatment. Lee's not where, okay, it's working. Okay. Today I want to talk about the importance of functional appliance and mixed dentition. I mean, I've been dealing with children, malocclusions for like 40 years and finding it very, very satisfactory. Now, posterior cross bites, deep over bites, anterior cross bites, open bites, narrow arches, underdeveloped mandibles, all these problems that these kids have need to be treated early. Now, 70% of the children in your practice have a malocclusion. So I don't know what you're doing now, whether you're referring them to orthodontists and telling the orthodontist is treating them early sometimes, or sometimes they'll say, come back when all the permanent teeth are up. And I definitely disagree with that. Very important to talk about airway, expanding airway. We talk about it all the time now, and I've been doing it for 40 years. When you develop the arches, upper and lower, you open up the airway, the nasal airway. When you bring the jaw forward, you open up the nasal airway. When you bring up the lower back teeth, increase the vertical dimension, you open the airway. So whoever you refer to, make sure who's ever treating your patients is paying attention to the airway and doing these three things. This is the first slide I usually show in any course, a constricted upper arch with a high palate. Now, if you don't expand that arch, you're going to end up having to extract permanent teeth. But if you expand the arch like I did down below, you can make all kinds of room for the permanent teeth and no extractions. Mothers don't want extractions. Patients don't want extractions. They want functional appliances to develop the arches and give beautiful broad smiles. Orthopedics is, I think, something that has to be understood. If the patient has a skeletal or a jaw problem, like a narrow upper and lower arch or lower jaw mandible underdeveloped, the solution is early orthodontic treatment with functional appliances. Don't delay and don't wait till all the permanent teeth erupt. Treat as early as age 5. This patient had a lower jaw back, okay? And you can't fix that with braces. You can't move lower jaws with braces, okay? You can only do it with functional appliances. So I used a functional appliance on her for 7 months and look at her profile. She looks fantastic. There's the airway. You can see how the airway was smaller on the left photo, and then you bring the jaw forward and it opens up the airway. So this is huge for people to get the airway open. In Europe is where many of the functional appliances started. Crooked teeth were solved with functional appliances, develop the arches and no extractions. That's the ideal way to do it. Orthodontics means teeth problems. Crooked teeth, space between the teeth, solution fixed braces, or clear aligners, Invisalign. They all have a place, but if you've got an orthopedic problem, you need orthopedic appliances, not just braces and not just aligners. In North America, fixed braces are the main thing that the orthodontists do. They treat in permanent dentition. And I think the extractions, I'm not sure if it's 50% now, but it was quite a while ago. And everyone's trying to do non-extraction, but unless you use functional appliances, you're very limited and you have to extract more. Let's look at the smiles. I like the smiles of the ladies, or the lady, better than the gentleman. I think I see dark corners at the side of his mouth, and I'm not sure whether he had developed those arches or not when he was younger. And so that's another one. And of course, this is Jen. She's got a beautiful broad smile, certainly no bicuspid extractions. Everybody wants that smile. Let's look at this guy, first patient, okay? He's age 8, and he's got crooked front teeth, constricted upper arch, and a narrow smile. He's got a fairly straight profile. He's a mouth breather. We have to find out why he's a mouth breather. His upper and lower jaws are lined up. We call that class 1. And there he is with the constricted arch and no room for the permanent teeth, no room for the lateral incisors, which is one of the things we look for, and also an anterior crossbite. So he's got a lot going on. So mothers want that fixed now. They don't want to wait until all the permanent teeth are up, because when the permanent teeth are up, the cuspids will probably come in like fangs. There's no room. Look at the tremendous attrition. Why are these patients grinding their teeth? He's grinding his teeth down tremendously. And will he start grinding his permanent teeth when they come in? So we look at a patient, how many functional problems have they got, how many skeletal problems, how many dental problems. We look at the teeth last. He's a mouth breather and he's grinding his teeth. We have to find out why. He's got a class 1 skeletal, which means the upper arch and the lower arch are lined up, but he's got a constricted upper arch. Lower arch is okay, but the upper arch is narrow. Dentally, he's class 2. So anterior crossbite, we got to deal with that first. And a posterior crossbite, we can actually deal with them both at the same time. We can expand the arch and also try and move that front tooth forward. Now, very, very important to measure this. You should get in there and measure from molar to molar. 27 millimeters is not nice, is not normal. 37 is normal. So a cotton roll is exactly 37 millimeters. So if you want to get in there and put a cotton roll between the molars, and if it fits in there nicely, then you don't have to expand the arch. The arch is perfect, and all the teeth will normally erupt on a 37 millimeter between the first molars. If you have a constricted arch and the cotton roll won't fit in there, you can be sure that the lateral incisors are going to probably come in lingually, or the cuspids are going to come in labially. So just why wouldn't you treat? Why would you wait and have all those bad things happen and make it more expensive to finish the case? So remember, the intermolar width is 37 millimeters. He needs 10 millimeters expansion. Now look at the lateral incisors. Those are deciduous lateral incisors. There's no room for them. we want to put in an appliance to expand the arch to make room for those lateral incisors. The lower looks pretty good. You don't need anything done in the bottom. There's room for the laterals and the centrals and the lower. It's just the upper is the problem. Severe bruxism. He's got airway obstruction. Okay. Patients brux. Everybody wonders why they brux. Well, patients brux to open their airway. At night, they're struggling to breathe because of an obstruction in the airway, and they're grinding their teeth to open up their airway. And that happens to adults too. So there's the tonsils at the back. Pushing the tongue down with the mouth mirror, you can see they're pretty big. And there's a study suggests that there's a relationship between sleep disorder, breathing, and bruxism. So when they took out the tonsil and adenoids, they got rid of the ADHD that kids have, and also got rid of their sleep apnea and their snoring. So we've got to get those out. So enlarged tonsils cause mouth breathing. The tongue is supposed to go on the roof of the mouth when you swallow, but the tongue moves down during swallowing. It's caused a constriction of the maxilla. So the constriction of the maxilla starts out with enlarged tonsils causing mouth breathing, which cause the constriction of the upper arch. So we have to get those tonsils out, and we have to expand the upper arch. This closes the airway, which is bad for everybody. So you got to refer to an ENT specialist to remove the tonsils. So we got to expand the upper arch, or remember the laterals erupt on the palate. Now, Orthonet Lab is the lab I've been dealing with for 35 years at least, ever since I got into that, doing these appliances. And Bill Van Evans is the guy that I deal with at the lab, who's fantastic. And they come in different colors. So that if it's a removable appliance, the patient can pick their own color. So the treatment plan is to expand the upper arch. Now, this is a removable appliance because the patient was very cooperative and the mother said he was. The parents make the decision. If the child is very cooperative, the mother will say, okay, removable appliance is okay. We'd like to take it out, clean the teeth, put it back in, everything's fine. And we've got Adam's class on the second primary molar and the first permanent molars. We had like 2 clasps on each side. We're going to adjust the appliance twice a week. Okay, I'll show you in a minute. So here's the appliance it's in. It's quite comfortable. He can talk and everything, and he can take it out to eat. And there's the key that you get that adjusts the appliances. You put that little key in that hole, and you turn it towards the arrow. And each turn is 1/4 of a millimeter, and you get 2 turns a week. Remember, 2 turns a week. And the patient does it, of course. Now, you see, we've expanded the upper arch, I think, about 8 millimeters. And you're not tipping the teeth. You're opening the suture, the midline suture. This is a skeletal problem with a skeletal solution. And we're opening spaces for all the teeth, and especially the 2 lateral incisors. There's room for lateral incisors and central incisors. Usually your upper arch and your lower arch is wide enough. Okay. We've opened 8 millimeters. So 27 millimeters was what we started with. We opened 8 millimeters. Now we're 35 millimeters. I'd be fine with that because when you put on the braces later, you will get more expansion. And also, if he's swallowing properly, we get those tonsils out, his tongue will go on the roof of his mouth. And when he swallows, it'll expand the arch. So we've gone from 27 to 35. And you can see the first photos, there's no room for the lateral incisors. You've only got deciduous laterals in there. And now there's lots of room. You've given him a chance now to have his treatment done without extraction of permanent teeth. So, I mean, it's just such an easy thing. He puts the appliance in, he turns it twice a week. You see the patient once every 2 months. It's such an easy procedure, and these appliances work so well. The laterals are coming in. They're coming in now beautifully. We might have to put braces on those front teeth for a short period of time to straighten those laterals out. But now remember, this is important too. When you take the appliance out, you have to leave it in. When you're finished expanding the appliance, you have to leave it in for at least 6 months to prevent a relapse, unless you put in some sort of other appliance. Okay, so that's important. You don't want to take it out and have the case relapse. So the mother decided, he didn't like the appliance after a while. He'd had a long time. We decided to put brace on his front teeth, and you can see the brackets on 4 front teeth. And then we put a TP arch in, transpalatal arch, and that we just leave that in until all the permanent teeth erupt. And that's more comfortable than the Schwartz appliance. Again, 27 to 35. Look at all those teeth. Now his teeth are all straight up there now with brace on 4 teeth. And we put a little Lingabond retainer so they won't move. And now we're just waiting until all the permanent teeth erupt. Okay, Lingabond retainer in the upper essentials. Straight teeth. Anterior crossbite, age 8. Straight teeth, no crossbite, expanded arch. Now we just wait till all the permanent teeth erupt. Pretty easy. So what we did, we referred to the ENT specialist to get the tonsils out. We put an upper Schwartz appliance, which is a removable appliance, expand the arch, 7, 8 millimeters, put in a TP arch, put braces on the front teeth and a Lingabond retainer. Not a lot of time spent. And we charge the patient $2,500 and the records are $500. Maybe today we might charge a little more. The mother certainly would be very happy to have this done and not have any teeth extracted. Plus, he looked better, right? As soon as he got him brighter arch, he's got a nicer smile and his front teeth are straight. He's better for self-esteem. So it's something you really should do. Now, if you don't want to do it, that's fine. Hopefully you're listening to this webinar. You're going to be interested in doing this, or you're already doing it. If you don't want to do it, find an orthodontist or a general dentist who'll do this for your patients. Don't let them wait and have bicuspid teeth extracted and permanent dentition with all the problems of bicuspid extractions, including closing the airway. Okay, space for all the teeth. Now we're just waiting till all the teeth are up. There he is, nice broad smile. Looks great. Looks pretty good, doesn't he? Great. All the teeth erupted after that into perfect occlusion. So the mother had never had to go for any more treatment. We made enough room for all the teeth. We straightened the front teeth. So the enlarged tonsils now reduce the size of the pharyngeal airway. Really important not to reduce the size of your airway. So don't let that happen. If you see large tonsils, you've got to refer and get those out. But large tonsils also cause a constriction of the upper arch. So you've got to get in and expand the upper arch. It also reduces bruxism. Hopefully the permanent teeth won't wear down like the deciduous teeth. I mean, look, that case turned out beautifully with just the treatment we did in phase 1. Beautiful arch. Maybe that cusp was a little bit rotated, but the mother didn't want that straight. Now, the other thing you're going to think about is obstructed airway can lead to sleep apnea and ADHD. ADHD is a serious problem for children because the children can't pay attention in school because they're tired all the time because they don't get sleep at night. They act up, they got behavioral problems, and they got ADHD. Really serious problem. And these kids have that, not good. It also restricts their growth when their airway's blocked. Do poorly in school, poor academic performance, and the ADHD with hyperactivity disorders is certainly something very difficult for teachers and parents and children to control. You can fix it all by opening the airway. Again, that's where we started age 8. Age 12, we're looking great. Age 8 with the cross bites. Age 12, straight teeth, no cross bites. I mean, this is a really nice case. And this does happen in at least maybe 50% of cases. Okay, crooked teeth, straight teeth. Constricted arch, broad arch. And of course, we talk about improving the behavior. He gets better marks at school. He's got more energy during the day. Increases his growth and development and eliminates nocturnal enuresis. I mean, there's so many things. I mean, can you imagine? I mean, if he hadn't treated him, he'd have all these problems. And it would certainly change his whole, it would just be so hard on him and his teachers and his parents. Okay, so the mother's happy, crooked teeth, straight teeth, broad smile, no braces, save $4,000. Everybody's happy. Doesn't that make you feel good when you take a little guy like that on the left with all those cross bites and crooked teeth and turn him into a fantastic young man with beautiful broad smile and straight teeth? I mean, that gives you a lot of satisfaction And you'll be attracting patients too. You start getting results like this, you're going to find that mothers will talk and you'll get more referrals you can have for your whole practice. Now, I wrote a book, Early Treatment for Children. Lee mentioned that, and it's 19 cases from start to finish. Probably, if you should take the course because you'll have to learn to do records and make a proper diagnosis. But once you take the course, this book is really, really good. 19 cases from start to finish. If you sign up for the course, you get that book free. Okay. Now, what if the patient doesn't cooperate? What if he doesn't cooperate? Maybe little guy, his mother says he doesn't cooperate. He doesn't do what he's told. And the mother said, this little guy, Danielle, he looks innocent, but his mother said he doesn't cooperate. So what we have to do with him, now there's no room for the laterals on the upper, the lower, and the lower laterals coming in crooked, and big teeth in the front, and no room for the laterals. Very important. No room for the laterals. Measure the intermolar width and look. If there's no room for the laterals, expand until there's room. On the lower, there's no room for the lateral. The sides is coming in crooked. You got to expand. Okay. So this is a fixed appliance. The nice part of this, and Bill Van Evans at Ortho makes those. Just tell them what you need. It's called a transverse transforce appliance, and it's got a midline force module, which works by itself. There's a spring in there. You just put it in, and you get about a millimeter expansion a month. And see, you can't take it out because there's bands on the second primary molars, bands, and there's a mesial rest on the first primary molars. And so it doesn't come out. You get a millimeter expansion a month. It's fantastic. He cannot take it out. It has to work. And there's the lower, a slightly different design. This is another design with a fixed expander with a nickel titanium coil spring, and that just expands by itself. Again, you get about a millimeter a month. So you can see they're very comfortable. There's nothing between the teeth. He can talk, he can eat, and it works automatically. So you don't have to worry about whether he's going to wear the appliance or not. It's cemented in. So you can see there's no room for laterals on the left, and we've expanded the arch, and you can see how nicely it's expanded, and there's room now for the laterals and the centrals. We find if there's room for the centrals and laterals, and you got 36 millimeters between the molars, or 37 millimeters, you're in good shape. You don't have to extract teeth. So the laterals have erupted. So we started out, you can see the spring, when we put it in, the coil spring was 4 millimeters open. And then over about 5 months, it expanded to 9 millimeters, and all by itself. Now, if you're happy with that expansion, what we do, that little tube that you see on the appliance, we take a bird beak plier and pinch the tube, and that deactivates the coil spring, and then it acts out of a retainer. So you can leave it in for a while other permanent teeth are erupting. Now we took it out. Looks like you can see a little bit of bleeding there when they came off. But boy, what a nice arch. You got lots of room for the laterals and the centrals, and hopefully there'll be room for all the permanent teeth. So this is such an important thing to do at an early age. Why would you wait until the lateral incisors erupt on the palate? Why would you do that when all you have to do is expand the upper arch, make room for the laterals, and they'll usually drop right into position. We remove the expanders and just let all the permanent teeth erupt. And we used upper and lower fixed expanders. The fee was $2,000 and the records were $500. And we had very little chair time. The appliances work by themselves. See the patient every 2 months, make sure everything's fine. They're brushing their teeth, expanders in place. I mean, it's such an easy situation, and 100% cooperation because the appliances cannot be removed. Again, look at the lower arch, all nice and straight. Straight teeth. Looks like those teeth are erupting pretty nicely, aren't they? We might have to make a little room for that cuspid there, but the centrals and laterals are straight and the bicuspids are coming in nicely. Yeah, it's just a nice way to do orthodontics. Why would you leave this and let it on in the picture on the left? Why would you wait till that gets worse? And maybe have to extract bicuspids if there's no room for the teeth when you can expand the arch and make room for all the teeth. I mean, it's the way it should be done. And to be honest, more and more orthodontists and general dentists are starting to use these appliances now. So Bill tells me, Bill Van Evans at Orthodontic Labs, he's got more orthodontists now sending in cases to be treated this way. So you have to decide whether your orthodontist is using these appliances to make room for all the teeth, or is he waiting and extracting bicuspids in permanent dentition? And if he is, I recommend you find someone who pays attention to the airway and pays attention to the appliances to make room. So make room for all the permanent teeth. No need to extract bicuspids. What are the effects on the airway? Well, when you have a constricted upper arch, then you have a small nasal airway and encourages mouth breathing. And remember, mouth breathing further causes constriction of the upper arch because the patient swallows and the tongue does not go to the roof of the mouth, it goes on the lower arch. So when you increase the upper arch, which we did on the first two cases, first of all, removable appliance, and this one with a fixed appliance, you increase the size of the nasal airway, which increases nasal breathing. You do not want mouth breathing, you want nasal breathing. You get 20% more oxygen with nasal breathing than mouth breathing. So you need to pay attention to the airway. This is the most, I tell my everybody that takes my course, the most important thing you can do, the key to health, is to give everybody a proper size maxillary arch. Period. That makes room for all the teeth. It opens the airway. It's the most important thing you can do for everybody. So if you have some kids like children like this, you've got to find someone to develop those arches, or you have to do it yourself. Now, this also, I have patients with constricted lower arches, which I've got a guy that I'm showing in most of my courses. He got a constricted lower arch because they took out his bicuspids. His tongue moved distally and closed the airway and caused sleep apnea. And so he came to me, and I expanded his arches and opened up his airway and put in a snoring appliance for him, and now he's okay. Because what happens when you close the airway, when you constrict the arch, the tongue goes back and blocks the airway, especially when he lies on his back. Okay, so here's level one. So Lee put this together here. So the courses are in Toronto, Chicago, and Atlanta. The fee is $12.95 per person. I guess you save $100 today. Webinar special, and you get 4 course manuals, which with colored cases of cases in all done in color, very, very clear. And I think they're the best manuals. Well, they're very good manuals. Okay. And there's the weekend. I recommend that you go online, rondoseminars.com, and look at the full course brochure. Okay, the full course brochure is online. Look it up, and you can see all the courses. Of course, we have courses on snoring sleep apnea, on TMJ, level 2 courses, clear aligners, case finishing. So really, it's a one-stop shop. If you get tied up with us and we're helping you learn, then we can carry you and keeping you learning all the time. Plus, we have study clubs you can join later. There's all the manuals. Boy, she did a good job of lining those up. So there's the dates, and you can look online and get those dates. And highly recommend you think about expanding your knowledge in orthodontics to help these children. We also have it online. So there's some dentists don't want to travel. Some ladies have a lot of kids to look after, and they'd rather do it at home when the children are sleeping. And it's 132 CE hours after completing the lab exercises. It's all approved by AGD, and also your provincial and state boards all approve our courses because they're AGD approved. Okay, so here's Angel, 8 years old. Okay. She's coming to you with a deep overbite. I can tell you, having treated thousands and thousands of patients over the last over 50 years, let's just say it's over 50 years, that females over age 20 with a deep overbite like that, most of them have temporomandibular joint dysfunction. Okay. So she's got a deep overbite. Many times the mother had a deep overbite and she had jaw problems or still got jaw problems. So it's very important that this is corrected right away. She's got headaches. So here's a little 8-year-old girl with headaches. Now, who's going to help her? Is her chiropractor going to adjust her neck? Is a medical doctor going to give her medication? Is she going to go to a massage therapist? I mean, who's going to help her? We're the only ones that can really help her. We got to get the cause of the problem, which is the deep overbite caused the jaw to go too far back and press on the nerves and blood vessels. How do we diagnose headaches? Well, here's a form we're going to include for you. Strongly recommend that you give this TMJ health questionnaire to all your patients so you can tell whether or not they have any pre-existing TMJ problems. It says headaches in the temple area, headaches front of the head, ring in the ears, deep overbite. I mean, here's a little 8-year-old girl who's got headaches, and who's going to fix her? Who knows how to fix her? We didn't learn how to fix an 8-year-old girl with headaches in dental school. And so if you don't treat early, you're not going to be able to help her. And you better do it right when all her permanent teeth are up too. If you start taking the bicuspids on her, she's going to have headaches the rest of her life. So what we do, we have to fix the deep overbite. So we put it like this, is kind of like a fixed bite plate. This is called a Rickinator, named after a dentist called Rick. Man made a convention. Bands on the first molars, mesial rests on the first primary molars, and that little ramp at the front, like an anterior bite plate. And you can't take it out, it has to stay in. Every time the patient bites up, the mandible will come forward and bite in front of that ramp. So there's the ramp, you can see it. So the jaw comes forward and holds it forward because the patient had an overjet and a deep overbite. Okay. So, and look at what we do. We have to composite buildups in the lower primary molars, or the patient can't chew. It also immediately gets rid of the headaches. I mean, it's just, if it took a day to get rid of the headaches, it's so fast, it's amazing. They almost feel better just leaving the office. Now, there's a big space at the back for the molars they haven't touched because the permanent molar can't come down. It's in the Rickinator. The lower molar will come up, though. The lower molar will come up on its own about 1 millimeter a month. So here's the problem. Here's the lower jaw back too far, pressing on the nerves and blood vessels at the back and causing all kinds of ear problems. I think she had ring in the ears, and they got stuffiness in their ears. They got all kinds of ear pain, and that's all coming from the jaw being in the wrong position. And it happens when you've got a deep overbite. The disc is in front. Sometimes when the patient opens, the condyle goes over the disc and causes a click, but not always in early cases. So the Rickinator moves the condyle down and forward, away from the nerves and blood vessels. Now, we were taught, I was, when I went to dental school many years ago, you're supposed to put the condyle up and back. Well, I've talked to some dentists that are still going to dental schools and finding out they're still talking about that. Well, I can tell you that's not where it's supposed to be. And the composite buildups open the bite too. So you move the condyles down and forward to the right position with the buildups and also with the Rickinator. So that's where you don't want it. The photo on your right is where you want it. You want the condyle down and forward. You want the disc to be in the right position, down and forward. You want nerves and blood vessels behind the condyle and not compressed. The photo on the left, the condyle is up too far back and then compressing the nerves and blood vessels, causing all kinds of pain and headaches. So put that in, headaches go away. But you have to do the buildups, or the patient has an anterior open bite or a posterior open bite and they can't chew. So you have to be able to chew and support the TMJ and eliminate the headaches. So you put the Rickinator in first, ideal overbite, and then just do the buildups and wait till those lower molars come up. Okay. So there's the lower molars that came up. Now we did decide to speed it up a bit, and I put a brace on the lower. You can see a bracket on the lower and a vertical elastic. So not very much mechanics. Put one bracket on, cement the bands on the upper, and put an up and down elastic, which you wore, which speeded up the eruption. But if you wanted to wait, it would still come up on its own without with elastics. I charged 2,500, records 500, and believe me, that mother would pay me a lot more if she knew I could get rid of her headaches, and I did. Okay, I mean, you feel so good. I mean, going to the office. I mean, not that I didn't enjoy dental dentistry. I did enjoy dental dentistry the first, I guess, 15 years of my practice. But then I took some orthodontic courses and started to learn how to help these children. And I feel I just love what I do. I've got what is known as I had a health orientated office, and now I've sold the practice and we've retained the same staff, and he's got a health orientated office, and we just love doing this daily. So again, the Ricanator holds the jaw forward, opens up the airway, and makes more room for the tongue, which opens the airway and also helps the temporomandibular joint, gets rid of the headaches. So easy. All I did was put in a Ricanator, which put the patient, ideal overjet overbite in the front, and put four composite buildups on the teeth. Again, we got the Ricanator in the book. What about her? Another girl with headache, 8 years old. Underdeveloped lower jaw, see? Underdeveloped lower jaw, retrognathic mandible. I mean, you can't fix that with braces. You understand? You got a bone problem. Look at the upper jaw, look at the lower jaw. It's a bone problem. It's orthopedics. You have to use an orthopedic appliance if you got an orthopedic problem. You cannot put braces on there, and you cannot start retruding those upper teeth. You can't take out bicuspids and retrude her front teeth. Look what's going to happen to her profile. You're going to move the upper lip back, make the nose look longer, and her lower jaw back, and she's got a TMJ problem, and you're going to not fix it. You're going to make it worse. So these patients need to be treated with functional appliances. The profession has to recognize orthopedics versus orthodontics. And of course, she's got a deep overbite too. She's got a deep overbite. Her condyles are up and back. It's so easy to figure out. When you got an overjet like that, you frequently have a retrognathic profile. And you cannot retract the uppers. You have to bring the lower jaw forward. And here's a little girl who had daily headaches. Her mother brings her home from school due to headaches. And believe it or not, I'm not showing it here, but 2 orthodontists wanted to take out bicuspids. 2. Unbelievable. Okay. No, I'm sorry, I'm getting the cases mixed up. It's not, 2 orthodontists did not say they're going to take out bicuspids this case. It's another case I was thinking about. Okay. So there's a twin block. It looks like quite a bulky appliance, right? I mean, it's a block on the lower and a block on the upper, and see how they're interlocking at the back there? So when the patient bites down, the lower jaw can't go back. The lower block hits the upper block and can't go back. Here's a little video of how it works. So 2 pieces, upper block and lower block. Expand the upper arch first with that midline screw. Put a labial bow on there if you want to move the teeth back. And that's how the patient bites. See, the patient has to bite forward or they can't bite at all. And then to fix the deep overbite, we're going to grind the plastic on the upper. But first of all, we have to expand the upper arch and make a proper size arch, make room for all the teeth. Then we put that in there, the blocks interlock and move the jaw back, and we take off the plastic there, and up come the molars, and you fix the deep overbite. Really neat. If you got a good cooperator, fantastic appliance. If you haven't got a good cooperator, I'm going to show you after this case what to use. So the blocks interlock at 70 degrees, bring the jaw forward, no surgery. No surgery, no extractions. Fix the orthopedic problem, get the upper and lower jaws lined up, no more retrognathic mandible. In 7 months, the jaw comes forward and stays there. It's an unbelievable. 7 months of wearing this appliance, the jaw comes forward and stays there. It's unbelievable. Every time I do it, I can't believe it. That's the upper block. You saw that. You put 2 Adams on each side on the first primary molars and the first permanent molars. And you make sure the blocks don't cover the lower molars, because remember, to fix the deep overbite, the lower molars have to come up. That's the way to fix the deep overbite. Get the lower molars to come up. Invisalign frequently will intrude the incisors to fix the deep overbite. This is very important. If you intrude lower incisors, you might have the patient looking good, but you don't fix the temporomandibular joint problem. Okay? So what we do now, we do Invisalign, we erupt the lower posterior teeth. Okay, and they come up, and that's a much better for the temporomandibular joint and the patient's appearance and long-term health. Okay, the twin block. So they look like this after 7 months, and then I'm not showing the whole case, but then you put buildups on the primary molars and just let the permanent teeth erupt, and then you do the case. But look at the face. Look at the face. It looks like she was a mouth breather too, but when we expanded the upper arch, maybe we opened up the nasal airway and we fixed the mouth breathing problem, and we brought the jaw forward, and she looks terrific. So I'm not showing all the cases. I just want to show you. And the airway opened up. Remember, the airway opens up. Bring the jaw forward, you open the airway. It's all about the airway. Remember, I told you there's 3 ways you got to fix the airway. Number 1, you expand the upper arch. Number 2, you bring the lower jaw forward. And number 3, you erupt the lower back teeth. That's it. If whoever is doing the orthodontics on your patient is not doing those 3 things, then it's not helping the patient's airway, and it's encouraging mouth breathing, which causes a lot of problems. Again, bring the jaw forward, open up the airway, and move the condyle away from the nerves and blood vessels in the back. So her headaches were gone. When I put that twin block in, the headaches are gone. So that's the finished case. There, we take tomograms. Now we're using CBCT x-rays. And you can see the condyles are close to the ear. That black circle back there is the ear. And you can see that there's not that big a space between the black circle and the back of the condyle. And now you can see a big difference. When you move the jaw forward, you're away from the nerves and blood vessels. And there she is. That makes you want to go to the office every day. Honestly, when you see a little girl coming in like that on the left-hand side, look at the eyes, not happy, going home with headaches, missing school. Imagine if that was your daughter, 8 years old. They take her out of school. She has to go home and sleep in a dark room and put up with headaches. She can't go to school. And who's going to help her? Well, guess what? You're the only one that can help her. You're the one that can get at the cause of the problem, not treat the effects of the problem. You don't want to give her drugs. You got to move the jaw to the correct position. But there she is on the right-hand side. She just look at her eyes. Look at her, how happy she is. Not only with her teeth, but with her jaw and no pain, no headaches anymore. So I love doing this. I'm not practicing anymore. I sold the practice, but I want to keep teaching because I want to help as many dentists to help as many patients as I can. And they play video games. So there's a couple of profiles I fixed. This was about 30 years ago, because you can see the camera wasn't exactly new, but what a difference. This one's interesting because I remember when she came in one day, she said her grandmother hadn't seen her for a year and said, "Heather, is that you?" Now, honestly, if you saw Heather on the left and a year later, Heather on the right, would you even know it's the same person? Looked like a completely different person. But that was an orthopedic problem fixed with an orthopedic appliance. There's a little girl too. Look at her lower jaw way back. Okay, we bring her jaw forward. You cannot fix that problem with braces or Invisalign. I mean, if you've got a class 2 case with an underdeveloped jaw and you try to use Invisalign, you're wasting your time. You got to use an appliance I'm going to show you coming up next. And again, jaw forward looks fantastic. If you want to improve the profile, open up the airway, eliminate the temporomandibular joint problem, eliminate the ADHD and all those symptoms, then you better start learning how to use these appliances. Here it is, last case. It's called a multi-FA, class 2 appliance. This is what you use on patients who don't want to wear a twin block because you might think they won't wear it. Believe it or not, when you motivate them, most do. But here's an appliance, it's brand new. It's absolutely fantastic. So here's Julie, she's age 12. She comes in with a crooked front teeth. She's got deep overbite. We want to get that fixed. She's got cuspids coming in because her arch wasn't properly expanded ever. She had no treatment. There's no room for the cuspids. They come in looking like fangs. So there she is, class 2 molar, class 2 cuspid. See, the cuspid is supposed to fit. The upper cuspid, as you know, is supposed to fit between the lower cuspid and the first bicuspid, and it's not. And she has an overjet of 5. So we got to bring her jaw forward. And that's the multi-FA appliance. It's really simple, okay? There's a bar that goes from the cuspid to the molar, and the bar fits on the mesial 1/3 of the cuspid. That one looks like it's almost in the middle. Should be a little more forward, I think. Anyway, and there's a bracket on the lower first molar, and you can see on the diagram on the right there's a Essex retainer on the lower to prevent the lower teeth from flaring. And all the patient does to fix this problem is put that elastic on after every meal. Change it 3 times a day. That's it. Very, very simple, very small appliance. No brackets on the front, no brackets anywhere except on the lower back molar and that bar on the side. Okay, so we got to fix that. So you have to measure it from the mesial 1/3 of the cuspid to the middle of the molar. Okay, mesial 1/3 of the cuspid to the middle of the molar. That's it. And a lower Essex retainer and a bracket in the lower first molar. How simple is that? Okay, and you get that from Orthodent. Okay, the lower Essex retainer will prevent flaring of the lower incisors. Okay, you have to use that. And you have to put a bracket on the lower first molar. Okay. So there it is. You start out with an S1 elastic. It's a 6-ounce elastic and goes from the cuspid on the upper to the molar on the lower. Very easy. I mean, patients don't mind it. Look like I did put a few brackets on the front upper incisors and line those teeth up with clear braces, okay, which the patient liked. But this is such a small appliance and so easy for them to wear. So you start out with the S1 elastic, 6-ounce for 1 month only. Then get the patient used to it. Then you go to the S2 elastic, which is 8-ounce, and you wear it for months 2, 3, and 4. Usually in 4 months, the patient is done. It's amazing how fast this works. So there's the patient with the multi-FA appliance, brackets on the upper 4 incisors. The elastic, start out with the S1, and then after that, you go to an S2. And guess what? There's the cuspid. In 4 months, the cuspid's back almost in class 1, and the molar's in class 1. Look at the molar back there. It's in class 1. Cuspid's almost class 1. I mean, is there an easier way to do it? I don't know how to do it any easier. You could use a twin block, but most 12-year-olds don't want a twin block. Younger patients, twin block, but you can also put this in younger patients. But you have to have some roots. Okay, you're better to do this in permanent dentition. So 4 months, got a class 1 cuspid, class 1 molar. So you start out there in the photo on the left. You got a class 2 cuspid, class 2 molar. Got an overjet. On the right, you got a class 1 cuspid, class 1 molar, no overjet, no overbite. That's kind of neat. So the elastic must have extruded the back molar a little bit to open up the bite. So it extrudes the molar, the bite opens, The Essex retainer prevents the lower incisors from dumping forward. I mean, the patient had to wear elastic all day long and all night, change the elastic after every meal, S1 elastic first month, S2 the rest of the time. I mean, really simple. The patient acceptance of this appliance is phenomenal. There's the patient with prominent cuspids and a deep overbite. And here's the patient with a normal overbite and no overjet. And cuspid came down a bit, right? The cuspid came down a bit, and you probably will have to move the cuspid back up a bit. Here's the high cuspid. And there's the cuspid on the right coming down a bit. That's okay. When you put the brackets back on, that everything will line up. But this is the easiest way to do it. I mean, the cooperation is so good with the patients. I mean, they just cooperate so well. So I just find it a great appliance, multi-FA appliance from Orthodent. We get everything from Orthodent. We get our supplies, all our brackets, bands, and wires, the multi-FA. We get all our appliances, retainers, everything from them. One-stop shop. So high cuspids erupted. I mean, so easy. 4 months. Can you believe it? Okay. So there's the overjet fixed. Big change. Just so simple. Put a few brackets on the front teeth, make her happy. Now, when you do this, then you might have to take off the FA appliance, and you might have to put brackets on for a short period of time just to finish the case, which we did. But I'm trying to show you this. So I want you to think about this. Okay, Jack Trout wrote the book Differentiate or Die. And think about it. If Kodak didn't differentiate, they didn't get into digital photography. They kept with the slides and Blockbuster video. I mean, how many people go down to Blockbuster video to get a video? No, you get everything on your TV. So you kind of have to differentiate. You have to ask yourself, do I want to do what all the other dentists do, or do I want to differentiate? And I'm hoping that you want to differentiate, not just to survive financially, but also because you want to help some patients. So think about it. Just quickly, 4 things you did not learn in dental school. You didn't learn orthodontics for children and adults. It's 75% of children and a large number of adults have malocclusions. Wow. And if you learn functional appliances and you learn about clear aligners and maybe a little bit about orthodontics to put some brackets on sometimes, you're going to have a really successful practice. And you're going to have some fun. You're going to help a lot of patients. TMD, 34% of the adult population is TMD, and lots of children have it. I mean, that's so rewarding when you saw those 2 little girls. One had a rickinator, one got a twin block and got rid of their headaches right away. And that works. The functional appliances work for adults and they work for children. I'm just showing you children today. Snoring, sleep apnea. Another thing you didn't learn in dental school, 50% of men over 50 snore. And 20% of the population has sleep apnea. That can be life-threatening. Severe sleep apnea, live 10 years less. Not good. And practice management. We do talk about practice management during the course to show you how to be more successful. Handling your staff and dental practice. We highly recommend your staff come to the course, or get a hold of our internet course on how to train the staff, because really they're a big part of the practice and they need to be educated and trained too and motivated. There's my consultant, Stock Manning. He's helped my practice a lot. And he said, do not focus on the economy, concentrate on your economy. We can't do anything about what anybody's doing with our economy, but we can concentrate on our practice and building our practice. And you really have to spend some time after hours on your practice. I love this one. Successful people do what unsuccessful people don't feel like doing. So some nights when I'm tired, I look at this and remember that, if I want to be successful, Maybe I won't watch that TV program. Maybe I'll read something on ortho, but I still watch TV, and but I, I think you have to work a little bit at it over and above your practice. You have to study. I love this analogy Scott Banning uses. The football team practices 95% of the time, 5% playing, and 3 hours per week. Most of the time it's practicing. Dental officers are just the opposite, right? We treat 95% of the time and maybe train staff 5% of the time. Well, maybe we gotta think about that. Have your staff meetings, try to train your staff, get them motivated, get them learning, and definitely learn about all the ortho and how we can help these patients. Remember, the key to your success is to try and match your management skills with the clinical skills. Well, that's it. I figured finished right on time. I can't believe it. I never do this. I never finish on time. It's 6 o'clock. I mean, it's like I planned it for hours. Has Bill Van Evans showed up yet?
I'm here, Brock. That was a great presentation. Thank you. And it's interesting just listening to you, because I quite often get people asking me questions. I've seen Brock talk in little sessions like this, and they ask, is it really that easy? How can it be that easy to change someone's life? And the reality is that it is that easy. When you get these kids that are at the right age, you absolutely can make life-changing changes for them. And it's just as easy as you say. And the other thing that I find that's tremendous about doing this type of work in your practice is one of the biggest issues that people have today is they're questioning how to do marketing to find these patients. Well, you don't have to do any of that. These patients are already in your practice. So it's, this is such a tremendous service that you can easily perform for patients in your practice of just exactly what you speak about.
And the other thing, Bill, if I can interject, is that when I started out doing this, you helped me a lot because I had to learn about the appliances and how they worked. But your lab and you will talk to dentists and help them with the design. We hope that we teach them in the course enough that they can design it themselves. But then I like the fact that you have a service that they can send the appliance to them, or send the records to them, send them the digital scans and the X-rays and the photos, and you will help with the diagnosis, help them understand. And I found you very helpful in the first couple of years. And now I also find you come up with a lot of new things all the time. I'm very impressed that you're so progressive because I remember some of the snoring appliances I'm using now. You were the first one that told me. You went over to Europe. You go to Europe on a regular basis and pick up a lot of good ideas from the Europeans. And you've just brought over, just tell them quickly about Gory and the functional appliance he's got that's brand new.
Well, so, as you'd mentioned before, a lot of the functional orthopedic appliances had their foundation in Europe. So I met a gentleman from Italy where, we find a lot of progressive thought takes place. And we now have a couple of different product lines. One is to strictly deal with tongue thrusting, tongue posture habits, and retained infantile swallow. So if you have a patient that should be developing an adult swallow pattern is not, it deals with that very easily, 15 minutes a day, and that's it while they're watching TV or a webinar maybe. And the other one is a series of myofunctional devices that can help with many orthopedic problems in terms of jaw advancement or jaw development. And again, the wear time is minimal and cooperation is fabulous. So I know that we've got courses that are teaching these techniques, and it's just so easy to integrate these in everyday practice.
So basically, you want to deal with Orthodent and Bill. Bill Van Evans is his name, and Orthodent Lab is the lab in Oshawa, Ontario. And it's your one-stop shop. He's always got these new appliances, the Froggy Mouth and the Amdrop appliance, which he's bringing over from Italy and introducing all over North America, which is helping patients, as he said, stop tongue thrust habits and learn how to swallow properly, putting the tongue in the roof of the mouth when you swallow. and also all the brackets, bands, and arch wires we get from Bill. Great prices too. Um, I mean, he's got quality, he's got prices, and of course he's going to help you with your cases. So I think wonderful to have you as a friend, Bill, for 35 years and helping myself and all my course participants to do this kind of work. And as you say, it's the appliances do the work. You just have to tell them to turn this key, or the fixed appliances work by themselves. But it's really important, I think, to get your staff involved. And I think in our course, the staff are permitted to come to the courses if they want. And I think 2 staff can come to session 1 for free when we show some of these appliances. But you can also get a staff course on the internet, and you can sit and watch it with them. But it's good to have them. I think you'll agree, Bill, when the staff are involved and motivated, they will help the practice tremendously.
Well, absolutely, because as soon as the doctor leaves the room, the patient's going to ask the staff the question: Does he, what's he talking about? Is this something new, or
Right.
is he any good at this? And if the staff is part of it, absolutely. We see patients with these types of problems get corrected every day in this office. We're happy to help, and keep the staff motivated, keep them educated and trained. Makes a huge difference.
Okay, well, that's great. Well, Bill, thanks for your advice and thanks for all your help over the years. And you're there, and I'm here and Lee's here to help everybody incorporate this in their office or expand their office if they want to learn some of the new things that you've got. And lots of courses you can take. And thank everybody for coming. And I really appreciate it.
I did have a couple of questions that came about, if you're able to maybe spend a few minutes on.
Okay.
Okay. So really good question. So this one's really good. So why are kids with airway problems smaller and struggle with concentration? Like why? They have an airway problem.
Well, they can't breathe. They can't breathe at night, so they're struggling to breathe. These kids with airway obstruction, you should see some of these kids. I've seen videos with the kids with large adenoids and tonsils. They're struggling to breathe at night. They're like choking, like adults do when they got sleep apnea. So without proper oxygen, they're tired during the day. I mean, if you don't get a good night's sleep, you're tired. Well, they don't get a good night's sleep and they're tired. And then they act up. They got ADHD, very serious problem for kids. And they get behavioral problems. They act up. They can't be controlled by teachers and parents. And they're fighting. They don't know where they're not healthy.
So why would they be smaller?
What's that?
So why would they be smaller? Because a lot of them are.
Oh, right. No growth hormones.
Yeah.
Thank you. Yeah, I missed that part. No growth hormones. When you don't get to stage 3 sleep, which is the 3rd stage of sleep, first stage of falling asleep, then the 2nd stage is light stage of sleep, which a lot of women, when they're pregnant and when they give birth to a baby, they got light stage of sleep because they're listening for the baby to wake up and so they have to look after them. You don't get the deep stage of sleep. If you don't get the deep stage of sleep, no growth hormones are secreted. So that's what happens. So these kids, unless they get the deep stage of sleep, if they just have the light stage of sleep, then no growth hormones, they don't grow. I mean, it's unbelievable. So you are doing so many good things when you use functional appliances and you pay attention to the airway. I mean, my course is called Airway Orthodontics because it's all about the airway. Everything we do opens the airway. When you extract bicuspids and retract the upper anteriors back, you're closing the airway. Okay? When you don't move the lower jaw forward and use retractive orthodontics, you're closing the airway. And if you extract teeth, you're closing the lower airway because there's no room in the lower arch for the tongue, and the tongue falls back and blocks your airway when you sleep at night. So I mean, it's a real serious problem. And Bill and I have been using these functional appliances for 35 years, but I don't think until about 5 years ago we realized when all these articles came out about the airway and how important it is. We were doing it right, but we weren't stressing it a lot in our courses because we just knew it was good. But boy, now with everybody concentrating on snoring, sleep apnea, and all the problems with health, and we're just stressing it more. We've been doing it right for 35 years.
Okay, perfect. Thank you. There is one more if you've got time for one more. So the question is, so why does simply advancing the lower jaw make headaches go away? That's a good question.
Well, I tried to show those diagrams because when the patient has an overjet or the patient has an overbite, the condyles are up and back, pressing on the nerves and blood vessels in front of the ears. So when you move the jaw forward with a ricinator or a twin block or a multi-FA, you're moving the condyle down and forward where it has to be. Now, remember, many of us went to dental school and we learned to put it up and back, and that was wrong. And when I go to courses, some dentists are still learning to do that, and that's wrong. Anybody who says that does not treat patients with temporomandibular joint dysfunction because they wouldn't get them better. They make them worse. So when you move the condyles down and forward with a ricinator, twin block, or multi-FA, you are helping that patient get rid of temporomandibular joint problems and opening the airway. So again, I made a big deal of the orthopedics versus orthodontics. You have to identify whether it's an orthopedic problem or an orthodontic problem. Orthopedic problems are narrow upper jaw, has to be expanded. Narrow lower jaw has to be expanded. Or lower jaw deficient, has to be brought forward. Or deep overbite, you have to erupt the lower posterior teeth. I mean, that's it. I mean, if you can keep those principles in mind and use the appliances that get you to get success with those principles, your patients are going to be healthier than you can possibly imagine.
Perfect. Okay, well, thank you so much. And thank you, everybody, for sticking around. I know we're a little bit late. And I would just want to look forward to seeing everybody again at the next webinar that we have coming up with Dr. Derezi. And thank you, Dr. Rondo, for your time, and Bill as well. And everybody have a good evening.
Thank you, Lee.
Thank you, Lee. Thank you, Brock.
Okay.
Bye, everybody. Thanks for attending. Hopefully, we've been able to help you with some good ideas.